Look here. For Williams. Hmm? Okay. Well, you have to go on this side and click it because I'm doing this side. Great. You're great.
I'm not as nervous as I was. Look at Audra. She's so cute. She's so
candle
It's so funny.
skull.
Men
And there's,
love
like,
to like
black-
be like black everything.
There's
is
black
weird.
velvet pillows with like a snake, and there's like black candlesticks.
He needs
We
to
go to
come see
Home
our
Goods.
house so he can see that it's not all
We
black.
go to Home Goods, and he like walks through. He's like, "You're gonna buy that for Alexa?" I'm like, I can't buy everything black for Alexa around Halloween time because that's everything in every
Everything.
store.
It's so true.
So I'm like, no, I can't. Can't buy that for Alexa too.
Also, you guys do not have to buy me one single thing. You
He's,
gave
like,
me so much
Very.
stuff.
Oh, I forgot that bouncer. Okay, it's a ballet. I'll see you soon.
Yeah.
Did you guys go through some of it?
Yes. I was gonna say I was gonna donate like a very specifically boy set, or do you
Mhm.
want it back?
Give it
I was gonna give
to
it to a women's shelter.
the kid in Jameson in the platoon that just had a little boy.
We didn't know someone had a little boy.
Jameson. I think it's a new guy or a one platooner.
Okay. Yeah. Let me check.
How are y'all doing?
Good.
I'm Kurt.
Alexa.
Alexa.
Emily.
Emily, how's it going?
Nice to meet
All right.
you.
You want your intro, don't you? The build up, right? The
Well,
hype?
you know.
Yeah? All right. All right, y'all. How's everyone doing? Enjoying the lunch? Keep eating. Well, we're gonna get cranked up again. All right. All right. So I have my guest already here at the stage with me. All right. A systemic view of indoctrination. Wait a minute. What? Aha. Hold on. Breaking news. We have a change. We are talking about sexual dysfunction, a holistic review of alternative treatment options. More sex, right? You got to love that, right? All right. So who do we have here? We have Dr. Alexa Estep, a licensed I knew, and I practiced this one. Acupuncturist. Was I close? And then this one I had to look up legit. Diplomate, right?
Oh, diplomat.
See, now I had to check because there's diplomat and diplomate. And actually, this is correct. This is diplomate, which is a certified by a board of examiners to practice in a specific medical specialty. Because I was like, diplomate. See, not only are you learning about sex and prostate cancer, but we're filling your brain with knowledge. Now you can be able to walk around going, there's a difference between diplomate and diplomat. Okay, I digress. Of acupuncture, certified by the National Certification Commission for Acupuncture and Oriental Medicine. Owner of, is it Punk Acupuncture? You like that, right? Obtain a doctor of acupuncture with a Chinese herbal medicine specialization degree from Pacific College of Health and Science located in San Diego. Studied a range of traditional Chinese medicine practices ranging from acupuncture, Chinese herbal medicine, Eastern food therapy, the 5-element theory. That sounds like there's got to be some kind of martial arts that's part of that. I know the 5, and you don't want to push me on this, all right? But I do know the 5-element theory. In addition to traditional Chinese medicine, also practices functional medicine incorporating lab testing, supplements, and lifestyle alterations to combine the best of Western and Eastern medicine. All right, so that's Dr. Alexa Estep, joined by Emily Teal, a licensed marriage and family therapist, specializes in couples therapy, working with the military community and treating sexual and intimacy issues. Sees the patients at her own therapy practice, Sage Therapy LLC in Virginia Beach. And this fall, excited to open. So is it already open? In 2 weeks. Folks, all right, this is breaking news here because in 2 weeks, you're going to be able to check this out. The Sage Wellness Suites, a building filled with multiple wellness professionals that support systemic and holistic methods of treatment, continues to serve as a clinical supervisor for the Chaplain's Pastoral Care Department at Naval Medical Center, Portsmouth since April 2019. She received her certification in relationship and sex therapy in 2023. All right. So I'm like, you're like, Kurt, enough with the introductions. Let's talk more about sex. So let's welcome our fine guest here.
That's a great intro.
It was a great intro.
Okay, so welcome. There we go. So we prepared 3 case studies that cover there we go. Erectile dysfunction, low libido, and an overactive bladder.
Yeah, so most times these types of sexual dysfunctions have a psycho-emotional and physical component. So Emily's going to cover the psycho-emotional and I'm going to cover the physical. So we're going to start with erectile dysfunction. So the 4 main contributing factors I see in my office for erectile dysfunction are hormonal, vascular, neurological, and psychological. And whether you're treating from an Eastern or Western point of view, the goal is always going to be the same: to balance the hormones, improve blood flow, enhance nerve function, and reduce stress. When you're treating from a Western point of view, usually this involves different types of medications. But when you're treating from an Eastern point of view, it's going to be acupuncture. So the number one question I get when it comes to acupuncture is, how does it work? And when you insert an acupuncture needle into a nerve bundle, it communicates with the nervous system to achieve all of these goals.
So treating through an Eastern philosophy, also we look at the psycho-emotional side. So looking at our first case, the emotional side of erectile dysfunction, considerations to include possible complications or distrust in the relationship. Maybe there's poor communication about sexual needs with the partners. Maybe someone's struggling with performance anxiety. There could be a history of past sexual trauma, or maybe there's a disconnection with the relationship or a lack of desire with partner. So those are all the things that we would treat in therapy. So our first case study of clients that we've been sharing this past year, we have a 61-year-old male. He had an intact relationship of 25 years. He had concern over his performance, his consistency with partner, and he didn't have reliable results from the medication prescribed by his doctor. So the client attended therapy, both as a couple and individually. We addressed his concern from a systemic approach. We worked with the client to reframe from a pleasure versus a performance-based model. And we incorporated CBT and DBT to help coping with anxiety. I then referred him to Alexa, and he was treated with acupuncture conjointly.
So for the acupuncture, we treated 1 time a week for 3 months, and he had no underlying medical cause that we could point to. And when that happens, I like to treat the big 4 that we previously talked about. So I've listed the acupuncture points on the slide, and I usually track week by week. And when you're treating erectile dysfunction, you want to talk about getting an erection, but also maintaining an erection. And so those are kind of the 2 symptom management factors that I look at. So week 1, he was able to wake up with an erection from a sexual dream, which isn't something that had happened for a really long time and was a success. By the 3rd week, he was able to achieve and maintain an erection. By the 6th week, he woke up with an erection and was able to have penetrative sex for around 10 minutes, which was a really large achievement. And by the 10th week, he was able to complete sex, which was great because he had been struggling with that for quite some time, about a 10-year history.
They graduated therapy and acupuncture together.
So next is low libido. My work with Emily has taught me that low libido oftentimes has a psychological component to it, but we know that that also affects physical change. And the 4 big ones for this are stress, aging, hormones, and exhaustion. And similarly to ED, we use the acupuncture to communicate with the nervous system. And through that, we can affect change by influencing hormones, neurotransmitters, even enhancing ovarian function. And for the adrenal axis and nerve stimulation with the exhaustion, we're really thinking about putting someone into that parasympathetic rest and digest state so that they can feel in touch with their body enough to have a libido.
Okay. There. Okay, so considering the psycho-emotional side with low libido, some emotional and different contributing factors that we talk about in therapy. Maybe there's a lack of connection with partner. Maybe there's some problems with self-confidence. We work on improving body image using narrative therapy and reframing. Maybe they're burned out with home life. I have some clients struggling with postpartum depression and sexual trauma that are contributing towards low libido, or maybe they feel general pressure in the relationship. So our case study that we shared for this client was a 43-year-old female, married with an intact relationship. She had a general lack of desire of being with her partner, a history of depression and anxiety. We worked on reframing her sense of self, worked on intimacy experiences using narrative therapy, reframing her perspectives to build confidence, and provided psychoeducation on the aging process, menopause, referred her to pelvic floor therapy. And we did some emotionally focused therapy with her and her partner on how to better communicate her sexual needs.
So for the acupuncture, we treated her 1 time a week for 6 weeks. And along with low libido, she was kind of generally exhausted, and her low libido focused on desire and arousal, which is a really important distinction to make when you're treating libido. While she was in therapy with Emily, used the acupuncture points I used every single week. And by week 2, she began having intimate thoughts about her partner throughout the day. By week 3, she was able to self-lubricate after partner-initiated intimacy. By week 6, she actually was the one to initiate sexual intimacy for the first time in 3 years. And by week 12, she had been engaging in sexual activity of some sort, multiple times per week for the past 3 weeks. So the last case study we're going to talk about is an overactive bladder. This one is one of my favorites to talk about, especially with urology, and it's an example I use often when I explain how acupuncture works to my patients. So there's an acupuncture point on the lower calf, and it actually is a muscular trigger point that has fascia that runs up to the muscles that wraps around the bladder. So if the overactive bladder is caused by a muscular dysfunction, if you release that fascia, you actually relieve pressure on the bladder and take away that urge incontinence. So whether it's nerve damage, muscular dysfunction, bladder obstruction, UTIs, or hormonal changes, you can use acupuncture to treat the muscles, the hormones, or infection. You can also use diet therapy, physical therapy exercises, or supplements.
So the psycho-emotional side of the overactive bladder, treating less of the medical side and the physical side within my office. We use meditation and progressive relaxation to help with anxiety and relax the muscles. We incorporated visualization exercise. We did some stress coping mechanisms to manage her anxiety, and we looked for to treat the root cause of the anxiety with CBT. So for this case study, it was a 54-year-old female. She was divorced and struggling with anxiety in her daily life. She mentioned having an overactive bladder. The issues were interfering with her job and day-to-day functioning, creating a cycle of anxiety for herself. I worked with her on providing anxiety and coping skills. This was a heavily referred case. I referred her to a urologist and acupuncturist, pelvic floor therapy. I worked with the client on identifying taking steps to make her feel more confident and to decrease her stress response of anxiety.
Now, on the acupuncture side, we treated 1 time a week for 8 weeks. And what I learned through this, working with this patient, is that stress and anxiety, especially caused by the divorce, made her overactive bladder worse, but it had been something she'd been struggling with for about 5 years. Those are the acupuncture points I used. I also used electroacupuncture, which is when you introduce an electrical current, and it just further stimulates that point. So by week 1, she reported no overwhelming urge to empty the bladder, just urgency with enough warning to make it to the bathroom. By week 3, her urine diary that we kept together shows bathroom trips had decreased by 20%. By week 5, she self-reported that the urine finally feels as if it is fully emptying. And by week 7, her urine diary showed the bathroom trips had decreased by an additional 18%. So at the end of our 8-week treatment plan, she had had no urine leaks since week 3, manageable urgency, and an overall decrease of 43% in bathroom trips.
Perfect. So that's just a little snapshot of how we've been working together this past year, combining our cases of treating things systemically and taking therapy and acupuncture and combining the process together. And if you want to get in touch with us, we'll be in our new building in just a few weeks together.
Yeah.
Yeah.
Thank you so much.
Right, so don't go anywhere. So there's time for questions. So yes, here we go. Hold on, we have a microphone coming to you. You almost got away, yes.
Hi, Emily. This is your neighbor. But anyway, is insurance cover any of these therapy or acupuncture?
Yeah, so all my services are covered by insurance, and Alexa works with a lot of nonprofits and helps secure funding. We've actually gotten a lot of patients' treatments covered, but you'll work with patients based on what they can do.
Typical copay.
A copay, that's like, I mean, it depends which insurance, it depends on your deductible, it depends on your treatment plan.
All right,
Yeah.
thanks.
Acupuncture?
Does acupuncture,
So right now, Medicare does not cover it. Medicaid covers it, but only for low back pain. So it's very funky what does and doesn't get covered. In terms of insurance, different insurance carriers do or do not cover acupuncture. And some of it is kind of like a base 10 treatments a year. Others require referrals from an MD. So it's really dependent on your insurance carrier. In my practice personally, I don't take insurance, but I know that there are acupuncturists in the area that do. So if it's something you're interested in, it's usually listed on their website and you can get some good information about whether or not your carrier is covered.
So what's the average price for 6 treatments, say, of acupuncture?
Yeah, so it really depends on obviously who you go to. I can only speak to my prices. It's about $100 a treatment. So a 6-course would cost around $600.
Thank you.
Yeah.
thank you.
All right, thank you all. Don't be shy if you have questions. This is the time to get that information so you can kind of like weigh all of the options. All right, so thank you, Emily and Alexa. So we now want to bring Dr. Mary Ojo-Cairns back to the platform to talk about restoring women's health after cancer, making it work for her, and overcoming barriers to intimacy. We have a sex theme going on here, right? Have you noticed that? Which is good. I mean, that's a quality of life issue. And so we need to find out if it's not working right. We need to find out how to fix that. All right.
Thank you. I wanted to address the insurance question. I know I don't have much time, but I'm going to just real quick. You know, a lot of us, many people don't take insurance anymore because it's challenging. It can make it challenging for the business, just because we all know insurance is not always the greatest thing. It helps us in catastrophic, but sometimes from like the preventative, it doesn't really help as much, especially for those who are doing innovative therapies like the acupuncturist, some things that we do in my practice. So what I wanted to say is don't let that prevent you from getting help if you hear, oh no, we don't take insurance, because many of us are willing to work with you to get you better, because the goal is not the procedure. The goal is not the therapy. The goal is you getting better. And so you're your best advocate for yourself by asking questions and, you know, talking to each individual practitioner that you may find interest in. So thank you all for paying attention to all of us, because there's a lot of information you're getting today, and I hope you're able to take back some of this information to your own homes and also to your friends and family. We're going to be talking about sex after cancer therapy. And you can also consider this conversation about just sex with aging. Sex is a physiologic process. It is something that all of us had happen so that we are here on this earth, right? And so it should be conversation that we're able to have, not only in a group like this where you're learning, but also with your spouse, because it does dictate how close you are in your relationship and the course of your relationship, but it also can have a big impact on your health. And so once you are, if you are unfortunately someone who's had cancer, that part of your relationship, that part of your life can be impacted a lot, not just by the disease process that you had, but also any type of intervention, surgical or medical intervention. So these two are individuals who, Marge and Henry, who are celebrating their 40th anniversary, something that almost did not happen to them because of cancer. Marge had a really progressive gynecological cancer and had to undergo surgery and chemotherapy that had a huge impact on her overall life, especially her sexual life with her husband. And so there are many things that had to happen for both of them to be able to reconnect. They had to redefine what sexual health meant to them. There is such a thing as sexual health. There is such a thing as sexual medicine. I practice it, so it does exist. They had to overcome the new barriers that were created by the cancer diagnosis and the treatment. They had to communicate with one another. I think part of the presentation, if you took anything away from what Emily's talking about, communication is always key. They had to establish an emotional connection, understand that there were changes in anatomy that would dictate changes in how they interacted with one another. They had to address the lack of sexual desire and arousal that can happen when you undergo these therapies. Enhance lubrication to end pain, work on techniques and strategy, and improve their overall sexual wellness. So there's often a misconception that when we are aging, that sexual activity stops, that it should stop. There's often misconception that at 50 you age out of sex. That makes no sense to me, right? So that's something that we have to get past. There's a survey that shows among men 75 to 87 years of age, about 40% report having been sexually active within the last 12 months, while 20% of women say the same. And so there are still people that are having sex as they age. And because of that, we have to make sure that we're having these conversations of why is it important to make sure that you understand how the sexual relationship and dynamics can change with age, but also with cancer. So what I hope we do today is shatter those misconceptions about sex after cancer and sex with aging. So the body is a marvelous machine. Like I said earlier, if you become menopausal, you have had a great benefit because you're still alive. You have life. You should take that and act on it. But chronic illnesses, changes in how our genitalia responds to stimuli, to touch, all of those can impact our sexual relationship and health. Conditions like diabetes, heart disease, osteoporosis, and more can have a negative impact on sex. So some of these common sexual disorders or some of the changes in sex oftentimes happen because of hormone conditions also changing, like we talked about in our my last talk. And so for men, sexual desire oftentimes decreases because of low testosterone. For women, it's oftentimes the inability to have climax. And all of that can be occurrence because of age, but also because of treatments from cancer. These are just representative of two studies, which shows that 60% of women, 40% of men experience sexual dysfunction from both cancer and cancer treatments. And so understanding that, then if you have a diagnosis, it's also great to have a plan for sexual health, care of sexual health during your treatments and then also after your treatments. So where do we begin when we talk about what can you do? We actually have to begin in the brain. Why do we begin in the brain? Can anybody answer that question? Why do we begin in the brain? I'll answer it, because the orgasm takes place in the brain. It does not take place in our genitalia. It takes place in our brains. And so understanding that, then we have to talk about the relationship with our partners, but we also have to talk about the relationship with self. We have to talk about stress. We have to talk about depression. We have to talk about anxiety. All of these things that can increase and do increase when we are being treated for cancer. All of these things that can increase and do increase when we age. And so we have to talk about brain chemistry and how those conditions produce hormones in our brains that will negate us being able to have orgasms, will negate us being able to have a healthy libido. The next thing we have to do is talk about, again, communication with one another. Communication is the key to having a healthy sexual life with a partner. There is absolutely no way that you can have a healthy sexual life with a partner if you are not talking about sex, if you are not talking about those things that may be uncomfortable. I oftentimes get asked, how do I talk to my partner about sex? The way you talk to your partner about sex is by talking to your partner, by having a relationship with your partner in which you are able to give information and also receive information. So it goes past just that moment or just about sex. It's everything. What is your relationship status like? When I have patients come to my office and we're talking about physical therapies or medicinal therapies to treat conditions after cancer, after chemo, and with aging, actually the first prescription I give is a visit to Emily. And it surprises me that oftentimes I have to sell that part of the prescription, not the hormone, not the procedure, but just sitting down and talking to someone about the condition and with your partner. So that is also key. We have to remember that intimacy is not just the sexual act. It is not just penetration. It is not just in the bedroom. Intimacy is also outside of the bedroom. And so when you're going through a stressful time with cancer and treatment, when you are aging, you have to build up other parts of your life as being intimate with your partner, and also intimacy with self. So you have to practice empathy. You have to have active listening. You have to build consensus together. You have to spend time together, right? In communication with one another. You have to be present in moments. These are all parts of intimacy. So sex and intimacy, they're interlinked, but sex and healthy intimacy and healthy relationships are just as important, if not more important, to continuing to have a healthy sex life after cancer. Now we come to the medications. So you see, it's top down. It's not the other way. So now we come to the medications that help with sexual function. Polypharmacy, taking a lot of medications, what you oftentimes do when you are being treated for cancer or as you age, can actually have a negative impact on your sex life. So there are medications that we all take, probably all of us in this room, because we are fortunate to live in Virginia Beach, that we all probably take pretty often during the year. Antihistamines, right? I take one every day. An antihistamine daily will kill your libido. And it's just a side effect. There are other medications like depression medications that can impact your libido in a negative way. Some of the medications that were talked about on the stage earlier for overactive bladder. My husband said it dries your mouth, it dries your eyes. He didn't mention this, it dries your vagina too, right? And so it's gonna have a negative impact not only on your desire for sex, because if it doesn't feel good, you're not gonna wanna do it, but it's also gonna have a negative impact on your ability to have sex. So we have to look at our medication list. know what medications we're on, know what medications can have a negative impact on our physical lives, on our hormonal lives, what medications can drive our testosterone down, and address that. We also have to be aware that there are medications that can counter those things too and help to improve desire and ability to have sex from hormone to non-hormone. Next thing we have to do is get into pleasure tools, sex toys. I call them devices. I don't know why I always call them devices. That's very technical, but they are devices. So, but getting to products that are on the market that can help to make sex better, help to make sex easier. Everyone in their bedroom who has a partner and has sex should have lubrication in their bedroom. Spit is not lube. Vaseline is not lube. Lube is lube. And not all lubes are the same. So if you're a woman and you've had a gynecological cancer, if you are a man, or any type of cancer really, if you're a man and you've had cancer, you likely have drier skin. Women, you likely have drier mucosa. You need something to make it easier to penetrate. You should use a lube. There are some lubes on the market that many people know, KY jelly, that's not a good lube. You want something that's aloe-based. You want something that is water-based. You want something that has a more natural ingredients because you're putting it inside. There are silicone lubes that are actually really good to use for those who have a lot of issues with extreme dryness because it doesn't get sticky. So there are really good options on the market. Pleasure tools, pumps, rings. If you're by my table, y'all saw I have some stuff there too. They should be part of the sexual experience. They are not an aside. There should be foreplay before you actually have sex, before you have penetrative sex. It is important for both partners to have foreplay. Why? Because it makes the penetration better, actually can make it last longer, can make it, you have a deeper connection. So all of these tools of the trade, they should be in your bedrooms. If they're not, hey, there's a lot of places you can get them that are very easy to access. Amazon is a wonderful place to buy pleasure tools. And no one knows it's coming because it just says Amazon on the packet, right? Just make sure you get it. Don't let somebody else open it up. But anywho, there are things on the market that are good. And then there's technology. So coming back to the point of why it's important when you have somebody that's doing more of regenerative procedures, it's important to ask them, hey, if I can't afford this, what else can you do for me to help me get that therapy? Because those regenerative procedures, I have one right here, acoustic shockwave. Those regenerative procedures can help to rebuild tissue that may have been destroyed by radiation, tissue that may have been destroyed by chemotherapy, tissue that has diminished in its utility and how it works, that just is changed by age. I put this slide up here because I think one thing that we don't oftentimes think about is STDs and STIs in those who are older. It can happen, and it does happen, and it happens oftentimes in those individuals who have a lower quality of tissue that is impacted because of cancer treatments or because of age. So you want to remember, if you're having sex with multiple partners, if you're having sex with a new partner, your new relationship, you want to remember to use some type of barrier method to help protect yourself against STDs, STIs, because the rate of STDs and STIs is actually increasing in older populations. And it's because of just this thought right here. We're not thinking about protecting ourselves. And then we have to also remember a party of one. There is nothing wrong with self-satisfaction. There is nothing wrong with masturbation. And actually, it is one of the best ways to learn how your body has changed as you age. It's one of the best ways to learn how your body has changed after cancer treatment, after surgery. It's one of the best ways to learn what pleases you. And so it's very important to not some people, because of cultural religious beliefs, don't masturbate, but there's actually nothing wrong with it. Again, it is a physiologic activity, and so doing that does help you learn who you are. staying active, staying exercising, eating well post-cancer, during cancer treatment. Important for all parts of your body, but I cannot express enough how important it is to exercise if you want a healthy libido. If you want to be able to desire your partner, you want to have a healthy, robust, full orgasm, you got to exercise. You want your ED to get better, you got to exercise. You want to have more vaginal moisture, lubrication with intimacy, exercise, 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 exercise moves the body, moves the blood, gets the joints to work better. It gets the heart pumping better. So, exercise all the way around. You have to do that. So Marge and Henry, they did all of those things. Again, they redefined what sexual health meant for them as a couple. They overcame those new barriers, changes in anatomy, changes in hormone level during cancer and cancer treatment. They communicated with one another. They established a new emotional connection, understanding that intimacy goes past the bedroom. They understood that there were changes in the anatomy that required them to bring new things into the bedroom to help have sex. They addressed the lack of sexual desire and arousal, and they enhanced lubrication and ended pain. They worked on techniques and strategies, and they improved their overall sexual wellness so that as years go on, they continue to stay connected as a couple and continue to have amazing sex. Any questions? Do we have time for questions? Okay. Don't be shy.
Hello. Just wanted to know which part of the brain
Mhm.
when you have the climax is activated.
So yeah, the actual response. So, you need three things to have a healthy orgasm, a healthy libido. You need anatomy that works. I mean, that helps, right? You want to be able to have an erection. You want to be able to have penetration, lubrication, all that. You need hormone balance. And and when I say hormone balance, I'm not just talking about, again, estrogen, testosterone. You want to have a good amount of dopamine that your body can make. You want to have serotonin levels that are appropriate. But then you also need mental clarity. And that's because the actual physiologic response, that orgasm takes place in the brain. It just feels good everywhere, but it actually happens here. Mhm. Okay, thank you. And so if anyone has any questions, personal questions, because this is oftentimes it is a personal, it is something that's very personal. I'm at my table.
Y'all got a little quiet on the sex questions. Y'all say, well, I don't want to sound too freaky. I got special questions. It's okay. We all grown-ups, all right? Oh, I see a kid there. Okay, so maybe it's best you didn't ask the questions. Okay. All right, very good, very good. All right, so that was making it work for her. Now making it work for him. All right? Now, man, y'all need to come with the questions, all right? Okay, all right? Let's not try to, I'm all macho, I don't have any questions, I'm doing fine. Man, just let's get the information, all right? All right, so we're bringing Dr. Langston back up, and so going to be talking about erectile dysfunction, making it work for him, overcoming barriers to intimacy. I mean, you heard from the female perspective, now the male perspective, and it was interesting because, I mean, one of the big takeaways was, I mean, sex starts before the bedroom. I know, men, that's hard for us to understand, it's like, what? I got to do all this talking first? Let's just no, yes. All right, let's bring in Dr. Langston. He's like, we will not have Kurt back as the MC, okay?
I love it. I do. I really do. Yeah, as I said, the fact that we can hear it from all sides. I thank you to Dr. Odrick-Cairns again for sharing that such a valuable input to hear it for the female side. And I think that I primarily take care now of men for erectile dysfunction. What a thing to commit your career to. And I don't know how I got to this point, but I can tell you that when I was in medical school, they said to me, you have a, hey, you have a good bedside manner. You should do oncology because you really have to be able to deal with patients in a tough situation and build a relationship with them. And you might be good at that. And I ended up going into urology, and then from there just ended up in this area. But I realized how much it's really the same thing, right? You're dealing with a situation where obviously different from cancer, but an individual is going through a very difficult, personal, intimate struggle with things that really shake them down to the core of who they are, to their identity, to their feeling of self and masculinity. When we're talking about both erections and, earlier I talked about testosterone. And so, men in our society, number one, they don't go to the doctor, they don't take care of themselves. And then, we all have this sense as we get older that, well, that's just how it's going to be. That's just how it is. I guess I just have to deal with it, yeah, so I do really enjoy getting to take care of men, getting to change that thinking. No, you don't have to stay like this. Yes, I can give you back this thing that you thought maybe was gone forever, and that is so vitally important to your sense of self and your identity. And I remember very much helping a guy out with one of the treatments that we'll talk about, which is actually a surgery that I do a lot of. And he said to me afterward, he was just so happy. And he said, doc, this isn't about sex. People think I would just have this done to be able to have sex. I'm doing this because it makes me feel whole. It makes me feel complete. It gives me my identity back. And that was several years ago, but that's when I really saw and started to understand, because I haven't lived through it, right? I can talk about it all day long, but I haven't lived through it. When I start to see how much it impacts men, it really just gave me a passion to care for men in this part of life. And so with that 10-minute intro, let me actually get to my talk here. With erections for men, again, testosterone may have some impact on that, but truly, this is a hydraulic problem, and we have various solutions that we'll talk about. So first, what is it? Who has it? What causes it? It is the inability to achieve or maintain an erection that's suitable for you to do what you want to do. It's your decision about what, I'm not going to judge that. If you're not able to function in your relationship or your situation the way that you're comfortable with or you're happy with, then that constitutes a problem that we can work on. How prevalent is it? 1 in 5 American men will have it, half of men over the age of 40, and that may be up to about 39 million men altogether. And there has been, as I kind of mentioned with the testosterone stuff, there's been a huge uptick in the marketing and the awareness around this issue right now, because you can get it online now. You can go to these websites and get the drugs and things like that. So again, no press is bad press. I'm glad that this is brought to the forefront of people's minds, but certainly we're available to help and guide you through everything about this. So as I said, it's a hydraulic problem. And so this picture here shows you what the penis looks like on the inside. There's basically these 2 chambers, and they look like sponge type material in there, just like a kitchen sponge, so that they could fill up with the fluid, just like a sponge can soak up, and they can empty out of that fluid. And that's really all that an erection is it's filling up those chambers with a fluid until they're so pressurized that they become rigid, and that's it. All right. And so that all must be accomplished by nerves signaling for the erection to occur. And well, let me say this, the nerves signaling for the blood vessels to open the faucets up and really pump in extra blood. Okay. So if any part of that is messed up, either the nerves aren't sending the signal, right? The brain, right, which is stimulated. Don't ask me what receptors or where in the brain, because I do not know. But the brain sends the signal. And if that signal doesn't get through, there's a problem. Or if the blood vessels can't respond and open up the faucets, then there's a problem. So it could be either one of those. But that is the process of how the erection works. So if you have trouble, it's going to be because of either a vascular problem, right? That's the blood vessels, right? They're not going to be able to pump the blood in and hold it there. Or it could be diabetes. Diabetes actually causes nerve damage. You may have heard peripheral neuropathy. So nerve damage can commonly be seen in the fingers and the toes and other parts of the body. But it can actually occur here too. The microscopic nerve damage impedes the signal from making it through. Medications can cause erectile dysfunction. And it could be a man with erectile dysfunction. It could be an early warning sign, specifically for heart disease. That's well established that it's an independent risk factor for heart disease, as well as diabetes, right, that we just mentioned, and prostate cancer, even though I think that's less so. And so this shows you kind of the reasons why men have ED, with vascular being the biggest one right here, and diabetes. You know, not being attracted to your partner is not on the list. And I really, you know, hate to think, even though it seems to be brought up every so often, you know, that there's a dynamic created inside the relationship, that if a man physically has a physiologic problem with these chambers, that, you know, somehow that's a result of there not being an attraction or something like that. And it can create a lot of strife. And I just hate to hear that. I hate to see that, because it's, again, very much a fault of these items here, which again are very prevalent in the, you know, American society these days. And it has a huge impact, we know, on quality of life all around. I've kind of hit this a few times already, but I'd just like this graphic to remind me, if I haven't already said it, that it impacts everything about a man's identity, not just their ability to have fun every now and then, but actually things right to the core of who they are, and their social lives, and their mental health, and their perception of themselves, etc. So we care a lot about treating it. Who can treat it? Well, your primary care doctor can certainly start, and they're able to go to, you know, so far as they can, and then urologists can take it from there on kind of some of the more advanced treatments. And then there's kind of the one of the options I mentioned, a surgery, which obviously has to be done by somebody who's a surgeon, and also maybe that has expertise in that. Now here locally, that's, you know, we do that, and we do it in very high volumes. But not every community has access necessarily to somebody with that type of expertise per se. We'll run through the different treatment options one at a time here. So the oral medications, right, that's the stuff that's very common and available. Viagra, Cialis are the name brands for the ones that are mostly out there. We're very lucky in this day and age that these should be very, very inexpensive, okay? 50 cents a piece. If you're not paying that kind of price, then you're not doing it right. You can get them through the discount drug card programs like GoodRx, if you've heard of that. And you can get the app on your phone. You can look at the different prices at the pharmacies, and you can find the pharmacy that's going to give them to you for that cheap, and make sure you're getting them there. You know, historically, before I started practice, probably they were $100 a pill, right? So if you took one, you better darn sure make sure something was going to happen, right? You know, so now that's it's a little different, right? Which is nice. So the pills that first of all, it's not like you take a pill and get an erection, right? You take a pill. Well, what does it do? It increases the blood flow. It's going to help your body when the signal is sent to have an erection, right? Remember, the signal sent by the brain through those nerves. When the signal arrives, it's going to help those blood vessels to really crank it open and keep the faucet open and keep the blood pumping in. Okay, that's the mechanism of the medication. So, in other words, you have to have that signal. You have to have that attraction, that stimulation in order for it to work. And the nice thing about these pills is they're in the system for a while. Now, Cialis or Tadalafil is in the system for about up to 36 hours, certainly 24 hours. So it allows you to be a little more spontaneous. You can take it at any time of the day and know that it's going to be in your system for whenever you get around to things. You don't have to worry that you're on the clock, you know, set a timer or something afterwards. So there's some benefit there, right, for that one. And they work in most cases. You know, I think if a guy is getting to the point where they have ED and they seek some treatment for it, this being the first line of treatment, it's probably going to work. Who knows how long it'll work? Maybe depending on your, you know, reason for having ED, may work for years, may only work for a few months, and unfortunately sometimes doesn't work at all. Men do frequently discontinue it. And, you know, just because it does require some logistics of remembering to take it, having it with you, you know, having some advance notice that things might occur, you know, et cetera. Now, men with diabetes are 1.5 to 2 times more likely to move on to other treatments. So I'll just say this real quick. You know, I'd given you kind of that foundation, that understanding that the nerves have to be sent down, right? And then I've just told you that the medicine works by when the signal gets there, it helps the pipes to stay open and pump blood longer. But again, if the signal can't get there because the guy's got diabetes and that's the mechanism for their troubles, then these pills aren't going to do any good, right? Because the signal never makes it there for the pipes to turn on in the first place. So the medication mechanism of action isn't able to really help out the guy who's diabetic nearly as much as it does for the guy who's non-diabetic. So men who are diabetic frequently have to move on to other options. They can cause some annoying side effects, really nothing dangerous, but annoying, and also things you probably don't want to have going on while you're trying to be intimate, such as headache, facial flushing, stuffy nose, and upset stomach. These are less common with tadalafil or Cialis than they are with sildenafil or Viagra, but and they're overall very rare, but they can occur. But it's nothing dangerous or nothing bad, right? What this does is it improves blood flow. So it improves blood flow down there, but it also improves blood flow to your head. So you get, you know, kind of that red in the face, kind of flushing, or you get a headache. But it's all from the same effect of the medicine. It just unfortunately has that negative effect on some people, though it's not actually dangerous. You cannot take the medicine if you have if you're on certain medications, right? Containing nitrates for your heart. And so there are some times where men are not eligible for the medication and we have to move straight on to the other things. What other things? Well, there's something called a vacuum pump. This is a cylinder that goes down over the penis and uses some sort of vacuum pressure created by a manual pump or a battery-powered motor to pull blood out of the body up into the penis and then trap it there with a rubber band that has to go down around the base. Let me just say it's not a wildly popular option. This was probably invented, I don't really know the history of it, 100 years ago when there was nothing else and they had figured out the mechanics of this. But currently speaking, not a great tool for use in intercourse. It does have a lot of very valuable use in kind of rehab for patients, and we certainly use them for various purposes. But as your kind of go-to for intercourse, only about 11% of men would say that it's their go-to. But again, if it works for you in your situation, then that's wonderful. We generally see a couple of things that when the pills don't work, we kind of move on to, and one of them is called intracavernosal injection. And that's where we actually teach and train you and your partner, if you want, how to actually inject a medicine. This has to be injected into the penis, okay? Nobody fainted? All right, good. So it seems bad, and it's not that bad, but what I tell men is it works. We can generally dial in the dose to get it to work, but obviously the hindrance to it is logistical. Number one, are you scared of needles and just say there's no way I could do any kind of injection to myself? Or, the other category is, well, sure, I could do an injection in my belly, but I can't go near my penis with that thing, or do you say, well, sure, I'll give it a try, right? And so again, it does generally work. If you are in a situation, which is, each situation is different as far as your relationship and your point in life and all that kind of stuff, where number one, you are okay logistically with doing this. And again, do you feel comfortable with the idea of doing it? My nurse does all the teaching and training. We've got hundreds of men, believe it or not, that do this at any given time in our clinic. And it's been around for about 50 years. So thousands and probably hundreds of thousands and maybe millions of people have done it overall, but it is an effective treatment. You do the injection within about 10 minutes, the erection sets in, and then we dial in the dose to where we get it to, last long enough, but not too long. So as you can see, you really want the pills to work if possible, because the options after that are less fun than taking a pill. But what I tell men is I can get you an erection. I promise, 100% promise I can get you an erection. There's not a lot of times that doctors can guarantee things, but I can guarantee you I can get you an erection. It just depends what lengths you want to go to, right? And again, that's your call, not mine. You decide what you want to do and how far you want to go, but I can get you an erection because I can either do the injections here or I can do a surgery that we do, which is called a penile implant. And it sounds really weird. And even after doing it for a decade and being one of the higher volume surgeons in the country doing it, I still don't have a great way to explain it just sitting here talking to you. If I show it to you, the one that we use in the office and all, I think it's very simple, but I know that at first glance it sounds totally bizarre, and I understand that. I'll tell you real quickly that as I said in the beginning, there's a chamber on the left and the right that fill up with a fluid, which is blood, until it becomes so full that it's pressurized. Okay, so if that's not working anymore, how can we recreate that in a exactly realistic way? Well, we do a minor little surgery where we get in there and we slide in a cylinder into that space that can inflate and deflate, but does the exact same thing. It fills up that chamber with a fluid, which is water that's held in a special reservoir deep inside your belly, and it just transfers in and out of that of those cylinders with the little control pump that's also inside the body, down inside the scrotum. And so it's a 45-minute outpatient surgery. I'm not going to say more than that, but I just I just bring it up because I wanted to tell you something really weird. No, because I again, I really do believe that this is a part of life that matters. And it is something where you could get into the weeds of, all the different nuances of all the stuff. Or you could say, you know what, this is how I try to break it down to guys. I say, look, is this part of life that matters? And guys say, yeah. Okay, well, is what you're doing now working? No. Okay, then let's go to the next thing. But like I said, everybody has a point at which they go, okay, like, yeah, it matters, but not that much. Or, and that's fine. That's totally, that's your call. I am just here to help you on your journey to get wherever you want to be. As far as the surgery, for instance, I do a lot of that kind of surgery. The oldest guys that I've done are 86 years old. I've done 3 guys, so they're 86. I can't seem to get the 87-year-old, but the 83, if you're 87, let me know. I'm looking for a new record. But the 86-year-olds, and I mean, again, it kind of news to me that that's still a thing at 86, but you know what? They want it, then good for them, right? I'm not, and I get some kind of sideways looks from the nurses in the operating room when they're like, really, are you putting this in an 86-year-old? But again, I'm not the judge. I'm not the gatekeeper. I want men to be able to pursue the life that they want to lead. And so that's, again, why we care very much about that. So I believe I should stop. And if we have a minute for questions, I don't want to cut into Dr. Hart's time, but I also didn't let you ask questions after the testosterone section. So if you have questions about either ED or low testosterone, anybody? We answered everything. I know there's one over here.
I just wanted to ask, do you still do the hinge surgery?
Hinge surgery. There's no
When we
hinges.
used to work technical. They put the implant in.
Yeah, no, you're talking about probably a malleable, right? Which is the kind of, it's always hard and it kind of had a bend to it. No, the surgery that we do, these are inflatable cylinders, soft and squishy. You can't even tell they're in there when they're deflated. Everything looks and feels normal. And then there's the little control pump in the scrotum in between the testicles kind of hanging out there. And you just kind of control that by feeling it through the skin and pushing the button, and that transfers the fluid from the storage tank, which is down deep inside where you can't feel it, transfers it out there, fills up those chambers, and gives a very realistic erection. You can't tell the erection apart from the real thing. You can't. It's exactly it replicates the natural erection really, really well. It's really remarkable, and it's not by any magic that I have as a surgeon. It's it's just the way the body's built. It's the way the body's built that you can replicate that outcome actually in a pretty straightforward way. Well, yeah, thank you. Anybody else? We good? All right. Thank you.
That is fascinating, right? I know some of y'all might be thinking about like the Nike pump tennis shoe, right? And that is, you know what? I think it's remarkable that there are 86-year-old guys that are saying, you know what, hey, I still got game and I still want to be able to bring it. And so, men, there are options out there. And, the thing is to have that discussion with your wife and say, hey, what do we want to do? Hey, before we bring up Dr. Hart, there is a raffle. And so we just want to make sure that everyone has they have filled out a raffle ticket. So has everyone filled out a raffle ticket, or do you need one brought to you? Hands in the air if you need a raffle ticket so that you can fill it out. And let's see, I see a few more hands. So 3, 4 more hands are going up. More hands for the raffle ticket than for the questions. We got to work on that. Okay. All right. All right. No need to be shy about the questions. All right. Well, we're now about to talk to the impact of high blood sugar on your well-being. The impact of high blood sugar. Dr. Anthony Hart, Director of Medical Operations for Centera Medical Group. All right. A highly experienced family medicine physician, focuses on disease prevention and wellness. He is devoted to providing personal, comprehensive, and continuing healthcare for all members of the family through all their stages of life. He lives in Virginia Beach, has 2 children. He volunteers in church activities and enjoys playing the trumpet. We're going to have to find out if he brought his trumpet, because that might be a kind of a nice way to kind of just break up the discussions that we're having here, a little trumpet playing. But let us give a warm welcome for Dr. Anthony Hart.
Yeah, thank you. Thank you. Thank you. Yes, I am a family doctor, and I've been at First Colonial, Centera Family Physicians at First Colonial, right next to the Beach General Hospital for 38 years. And my boss and colleague, Dr. Robin Anderson, talked earlier this morning. I think some of you would have heard her. So yes, I'm going to start out talking about diabetes. Diabetes is super common and an important thing to understand. So I'm going to try to break it down to things that are understandable. First of all, if I could get people to raise their hand if they do have diabetes here. Yeah, that's about right. I have diabetes also. Yeah, it's common and it can be serious. Controlling it is super important for not only your well-being, but also you die early with diabetes if you don't control it. So a couple slides. Yeah, so this slide kind of breaks things down. Glucose is really important fuel for the body, and it goes to many parts of the body, muscles, heart, brain, kidney. It's important that the blood sugar gets to all these different organs. So glucose, sugar is good. It's just how you control it. Yeah, this is a pretty busy slide. I'm actually going to go to the next one. This kind of breaks things down in a real complete way, but I want to kind of get to what's more understandable. This is definitions. So what's the definition of diabetes? You first have what's called impaired fasting glucose. So impairing fasting glucose means technically your sugar is between 100 and on this one 125. So that means it's not perfect, but it's not diabetes yet. Diabetes, really, the definition of diabetes for us now is something called hemoglobin A1C, which is greater than 6.5. So hemoglobin A1C, I think the diabetics in the room, I think have probably heard of hemoglobin A1C. It used to be we only talked about your blood sugar, but now hemoglobin A1C is a common lab test that every diabetic should be getting a hemoglobin A1C on a regular basis. So the way it works is somewhat mysterious, but what it does is average out your sugars over 3 months' time. So it gives you a number, and a number, the scale of numbers is, if it's over 6.5, then that's the definition of diabetes. But many people, when they're out of control with diabetes, could have an A1C of 10 or 11 or 12, which again is something that needs to be worked on and controlled. But that's the key. When you go to your doctor for diabetes, I'm assuming those here that say they have diabetes, I think that's a number for the doctor to talk about, but also for you to get in your mind is you should know what your A1C is. And if that can be controlled, then your diabetes is under control. So more important to talk about hemoglobin A1C than glucose number per se. Yeah, there are a lot of reasons why blood sugar is high, and we really don't know what causes diabetes per se. There are a lot of things associated with it, and that can make it worse. Family history is important for diabetes, but you can have um, all your relatives with diabetes and you not have it. Um, Nutrition is important. Being overweight is certainly a problem with diabetes, but it doesn't cause it in itself. Many people are very overweight and don't have diabetes, and people can again be at a normal weight and not have diabetes. So yes, once you have diabetes, these things are important to control, but the actual underlying cause of diabetes, we don't know, but we do know that if you have it and don't control it, it has devastating effects on your health. So this is really the key, right? Is if you have high sugar, do you feel it? I think a lot of us diabetics think that we can feel it, but not necessarily. It's pretty silent, just like high blood pressure is pretty silent. So you have to have a blood test to know what your sugar is. But if the sugar is consistently high, why does that matter? Because it's not something like a broken bone that makes you feel bad. It doesn't put you in pain. You can be feeling just fine. In fact, sometimes controlling your sugar can make you feel temporarily not so good because it's kind of a good feeling in a way to have sugar in your body. But these are the reasons why it's important. Why it's important to control the sugar. As you can see here, a big problem is for a diabetic is often have early heart attacks. Heart attacks and strokes, you're at much more risk if you have uncontrolled diabetes. Then I think Dr. Langston mentioned the neuropathy. Problem with the blood vessels is important, but problem with the nerves is also very important. A lot of us that have diabetes have problems with our nerves into our legs. And I'm guessing that those of you who said that you have diabetes may well have neuropathy, which can be mild problem, or it can be a really painful problem in the legs in particular. There is medicine for it, but again, it's a troublesome thing. And then, of course, the kidneys is a big problem. Again, when your kidneys are starting to fail, you don't really know it unless you have blood tests to show it. You could have kidneys that are getting much worse from diabetes, and it can get to a point where your kidneys fail and you need dialysis. So again, that's a pretty devastating effect of diabetes. And eyes, again, people do go blind because of diabetes, so it's really important to have your eyes checked, and we usually recommend a yearly check with an eye doctor, because again, these things are all silent, but they can be devastating and cause problems. So one of my take-home points, I think, is if you have diabetes, it's really important that you have a provider that you feel good about and feel good going to on a regular basis, and that the two of you can kind of build up a trust relationship, because it's not like, I totally respect surgeons, but a lot of times you fix a broken bone and it's hello and goodbye. I mean, but this is a lifelong thing. So it's very important you have a provider that you're willing to and do go to on a regular basis, because these problems we're seeing up here are problems that are devastating, but also you won't know it unless you get checked on a regular basis. And here, this is the cost of diabetes. I think that's probably more us as a society that cares about that than everyone individually. But I would say one of the things about diabetes, and again, not knowing what medicines you guys are taking, metformin or glucophage is our basic medicine. It's relatively cheap. and easy to obtain. Once you get past metformin, though, things can get more expensive. You know, these days everyone talks about Ozempic, right? Ozempic, you know, the movie stars love. If you have diabetes, you can. It's a good medicine. It's certainly not the first medicine to use. You know, a simple injection once a week, it does work for sugar. If your insurance covers it, great. It can be like $25 a month. If insurance doesn't cover it, it could be $800 a month. For most of us, $800 a month is a lot, and often not possible. So again, diabetic medicines can be expensive. Metformin or glucophage is always the one to start with. Insulin is used basically for, not to be technical, but if someone has what's called insulin dependent diabetes, which is usually something that you know about as a child, you need insulin. That's the type of diabetes. For most of us that have type 2 diabetes, insulin is sometimes used, but usually pills and injections other than insulin first. Mainly, when I'm talking here, I'm mainly talking about type 2 diabetes. That's by far the most common, and that's kind of what most adults have. The type 1 diabetes is a huge challenge that affects often in teenage years and young adulthood. It's a major problem, but that requires insulin and definitely needs a diabetic specialist. Yeah, a little bit about high blood pressure. You know, the two often go together. Most of you that said you had diabetes, I guess you can raise your hand. Who has high blood pressure in this room? Yeah, it probably some of the same people. I have both myself. Often it's common to get both of them as you get over 50, and certainly in your 60s. You can be fine before that time, and then these two diseases kind of come up and often come up together. In fact, most patients that I see with high blood pressure, diabetes, also have high cholesterol. Usually the three go together, and it's important to control all three because the three together cause those same problems: heart attack problems, stroke, you know, trouble with the kidney, etc. So oftentimes it's the three conditions together. High blood pressure is notoriously silent. In other words, if everybody in this room said, "Do you have high blood pressure right now or not?" You just have no way of knowing. I know it's common to say, "I feel like I have a high blood pressure," and sometimes that's more if you feel anxious. But it is a silent disease, and you cannot be reassured if you're feeling fine that you don't have it. So high blood pressure, hypertension is related to pressure in the arteries. Like diabetes, we don't know the underlying cause of hypertension. And it is kind of amazing with all the great research we have, two of the most common diseases that affect us intimately, diabetes, hypertension, we really don't know the underlying cause, but we know the effects if you don't treat it. So this slide is basically the same as the diabetes slide, isn't it? Is what part of the bodies does it affect? So it's stroke, the eye, heart attack, kidney failure. And the thing is, they're additive. I mean, if you have high blood pressure and diabetes, they both make these things more common. Again, a slide that kind of emphasizes the same point. And the amount of how far your blood pressure is out of control does matter, certainly. We always go, the traditional thing is 140/90 or below is what's suggested. And that can be more strict for a diabetic or someone who has kidney problems. But that's 140/90. It's important to know, just as your A1C, to know what your blood pressure is. It's important for your provider to know that, but it's really important for you personally to know certain basic things. And your blood pressure and your A1C are two of those things. more definitions. And again, like I was saying before, it's the 140/90 is the basic number to know. If you're consistently below that, then that's good. Consistently above that, then some sort of treatment is necessary. We often think if you lower your salt consumption, that can lower your blood pressure. If you exercise more, you keep your weight under control. But you can be perfect in all those different ways and still have high blood pressure. So it is something, medication is often necessary and often necessary for life. Yeah, this is a slide, basically healthy living slide. And I am totally agreement with all these things, reducing stress, drinking water, eating healthy, all these things. But for both of these diseases, I guess I'm saying, get a good relationship with a provider, see them on a regular basis, know what your numbers are, A1C and blood pressure in particular. Yeah, again, healthy living, totally important, but also, again, these are things that you need to be treated for. Open to any questions, if anybody has any questions about diabetes or high blood pressure. Yes, sir.
And I have an annual physical every year with fasting glucose that's always normal. Should
Yeah.
I have a tolerance test at any point or not? Glucose tolerance.
My ears are not great. Could you, at the last? part?
Should I have a glucose tolerance test at any time?
Yeah, no, glucose tolerance test not necessary at all. What may be helpful, and we used to use glucose tolerance test a lot, especially for pregnant women, but glucose tolerance test not necessary anymore. If your blood sugars are borderline, the next test is the A1C, hemoglobin A1C. That's a reasonable test. And like I say, if it's below 6.5, then you clearly are not a diabetic. If it's above that, that's the most reliable test, hemoglobin A1C, and readily available. I'm sure your provider is well aware of it.
Thank you.
You're welcome. Yes, sir.
Do you have any suggestions around sugar substitutes?
Sugar substitutes.
Stevia.
Yeah.
Stevia.
Yeah, stevia is probably the best. Yeah, stevia is more natural than others. So I think that's it's a good idea. Yeah, and it kind of brings up the whole idea of a nutritionist and foods. There are we have in our office and now in Sentara, they call it the journey to success, and it does talk a lot. It's a group of people with diabetes, and they often do talk about eating. What are you eating? What's good? It's a long-term thing, right? So you can't get on a really strict diet where you don't like food anymore. So you have to be reasonable about it. But certain things are clearly more a problem than others. Unfortunately, bread, rice, pasta. I'm an Italian. It's hard to limit pasta, but those are the things that are very important in addition to dessert. But it's not getting rid of them, not stopping to eat them, but how do you get it under some control?
Okay, we have one last question.
Yeah, you mentioned the A1C. In order to get an accurate A1C over a 3-month period, don't you need to take your blood work every month? Or do you?
Again, my ears.
Your A1C,
Yes,
you said it's over a 3-month period.
yes, correct.
And you need that blood work done every month then, right?
No, I mean, it's unusual to have to get blood work every month. A kind of a standard time frame for someone with diabetes, high blood pressure is to see someone every 3 months and maybe less often, but to do it every month, again, would probably not show the changes. So I would say every month would be a special circumstance, more commonly every 3 months, and that's where the A1C could show a change.
And you can control it through diet and exercise.
You can control with diet. So he said,
Diet and exercise. Yes.
absolutely,
Mhm.
absolutely. You can control with diet. You have, it sounds like,
I'm a witness.
Yes, yeah. I mean, you can control with diet for sure. I guess my comment was a little bit is it's not like you want to do this for 3 months and be real strict and control the diet. And if you have 20 or 30 more years to live, you have to get a diet that's reasonable long term. Okay. Okay. I'm sorry. I can come to you actually. I'll come to you and ask that question. Absolutely, diabetic support for type 1, you say? Okay, now that's going to be there is that, and I can give you some thoughts on that.
All right, Dr. Hart, thank you so much. Hey, before we continue with the program, raffle drawing. And I'm picking? All right.
I'm gonna dump them on you and whichever one.
All right, blind pick, all right? Okay. This looks like Jacqueline Betha? Butha? How close am I on that one?
Jacqueline Butler. I'd say Butler, but it's 989188.
All right. Congratulations. Dr. Langston is back. Prostate 101. Prostate 101 and BPH, male voiding dysfunction. Not avoiding, male voiding. All right, Dr. Langston.
Isn't he great? Can we just one more round for Kurt? Thank you. All right, there was some claps there. We know you're awake. Those people that were awake and clapped, thank you very much. All right. Third time's a charm. For me here, we're going to talk about the prostate. We crammed a lot into 20 minutes here. So again, I'll go quickly and try to stay on time. We'll just try to hit some high points. What is the prostate? What good does it serve? Why bother with it? That kind of thing. So it is a supposedly walnut-sized gland. It sits at the base of your bladder. Here's the deal. It sits like a donut around the base of your bladder. The urethra, the water pipe, comes down through the donut hole, through the middle, and then funnels down and out the urethra, out the penis, right? And so that's where it is. What does it do? It makes fluid that's involved in ejaculation. So it has some of the fluid, only sperm. Here's your trivia question of the day. Your factoid, only sperm come from the testicles, right? All the fluid that actually accompanies the sperm is made up in the prostate and in what are called the seminal vesicles behind the prostate. So that's what it does. So once you're done having kids, it just causes trouble after that. And so, but that's where it is. And it can do two things, right? You can have prostate cancer, or you can have enlarged prostate that causes voiding difficulties and enlargement of the prostate. And just because you have one doesn't mean you have the other, okay? So again, maybe this matters to you. Maybe it's something you'll keep in the back of your mind for when your neighbor comes to you. If a guy starts having trouble peeing, it doesn't mean they have cancer. In fact, it's usually quite the opposite, right? It's that benign, non-cancerous enlargement of the prostate that happens as you get older. And we'll talk about both of them. So the prostate, you can see over here, this is an MRI, and you can see this big middle part here, and then there's an really thin outer shell here, okay? So it's just like a fruit where you've got the rind on the outside edge, the ring here, and then you've got all that pulp in the middle. And so the reason that I can say confidently that most of the time prostate cancer doesn't cause urinary difficulties is because prostate cancer usually pops up in that shell, okay, in the rind of the orange, where it grows basically outward, right? And so if you think about the orange analogy here, you've got the urethra in the middle, right? Like I said, think of it like the donut. You got the water pipe going down through the middle there. So you wouldn't notice any urinary trouble if something was growing on the edges around the rind there. It's really when this central portion that surrounds the donut hole, right? That's what's called transition zone. When that starts to really grow as you age, that's what causes the urinary trouble. So the prostate does grow as you age. It does so for every man. almost every man. Sometimes we'll see old guys with small prostates, but for most guys, there's going to be some degree of growth. It's very genetic, right? It's very much a genetically based thing. So some guys, it's going to be real rapid. It's going to get real big in their 50s. Some guys, it's not going to get real rapid and grow till their 70s, some in their 80s. But it does generally grow as you get older. We also know that prostate cancer happens to men as they get older, but again, totally separate from the non-cancerous growth of the prostate. That happens with age as well. It starts to really kick in the 50s and then 60s, 70s, and then on up to the point where you have a very, very high chance, if you're going to live to 100, that you'll get some degree of prostate cancer growing in there. So again, BPH is the non-cancerous growth of the prostate that occurs and causes urinary issues. And you can see here kind of what that looks like. So over on the left, you've got the normal prostate, okay, and then the bladder right above it. And the urine has a nice flow, nice channel to flow down through there. And here is the prostate getting enlarged and big, right? Think that donut, basically, as the donut grows, it can't expand outward because it's in a tight spot down there in your pelvis. So it can't really expand outward. So what does it do? It just pinches off the donut hole, right? And it crimps off that tube, and then there's nowhere for the urine to pass through. And so actually, if anybody is interested, this is a really nice drawing because it shows the bladder wall being very, very thick. You see that? The bladder wall is very thick compared to here, because that's the dynamics of how this works, is as the prostate starts to block more and more and more, your bladder starts to squeeze harder and harder and harder to try to accommodate, right? And so that actually process can go on for years like that. Eventually, when you start having a lot of trouble and really start to struggle, that's because the bladder says, I can't do anymore. I can't squeeze any harder. I can't generate any more pressure, buddy. You're on your own. And that's when you really start to notice more of the symptoms. But you can see, like any other muscle in the body, as the bladder works harder, it's going to get thicker and stiffer and maybe not want to work as well. And so that can lead to a lot of bladder related issues actually in men, in all of this as well. So what symptoms does it cause? Well, so for one, slow stream, right? If that channel is crimped off and much more narrow, then the urine's not going to flow out as well. And you may have to strain or not be able to empty out all the way. And then you also get to urinary frequency, where you're going more often, urgency, where you got to drop what you're doing and rush to the bathroom, and then getting up at night. And those last three, like I said, can be in some ways attributable to prostate, but can really be attributable to the bladder when the bladder's acting up and not, for instance, not wanting to fill up to a nice full capacity. It wants to stay kind of tight and tense because it's in this mode of struggling and struggling and struggling to push the urine out. So it's not relaxed and filling up to a nice full capacity anymore. It stays real tense. And then you're going every hour on the hour, day and night because of that, right? So I kind of already talked about this. Here's just another view of that, right? When this tube gets completely obstructed here, the bladder is going to get that real big thick wall as it's trying to squeeze and push against that obstruction. And here's the actual view. I don't know if you can see it that well on the screen, but if we look inside with a camera, just the way urine comes out, we go in with a tiny camera. And you can see these pictures on the bottom. Here's what it's supposed to look like. It's a nice wide open channel. There's just a little bit of tissue on the left, a little bit of tissue on the right. Here's starting to show that it's kind of starting to encroach. They're draping in and blocking off. And then here you can see complete obstruction. There's no channel there at all. That tissue has grown so much that it's completely pinched the channel shut. So it can cause trouble. It can cause you not be able to go at all. It can cause kidney failure. It can cause bleeding, infections, and stones, and it can really affect quality of life, right? So men avoid traveling. They won't go out and they won't do social things. They won't go to church. They won't see their friends because they have to stay close to a bathroom. And it really disrupts sleep. It wrecks sleep, right? Again, maybe this is you, or maybe you're just going to be more sensitive to it when you hear your friend talking about it. But talk about not sleeping, right? I mean, this is like, remember back to the days when you had a baby and they got up 4 times at night and you were just a zombie all day, right? I mean, I'm still in that phase, but that's how it feels. And I can't imagine, it's got to be rough. So a huge impact on quality of life. When we see you for this, we're going to do a history and physical exam. We're going to check your PSA blood test. We'll get to that in a minute. We're going to examine the prostate and see how well you empty it out, right? So that's one thing that most primary doctors don't have access to. It's just a machine that right there on the spot can measure how much urine is in the bladder. So if you go to the bathroom and your bladder is this full and you go pee and it goes to this full because you only got a little bit out, but that's the best you could do, then that's a problem. And it goes right back to full again and you're back in the bathroom an hour later. But you know, we can actually measure that and see numerically how much is left over after you void. And that's a really important measurement in my opinion. But we're usually the only ones that have that machine to do that. We do the rectal exam, not just to be mean, but also to feel the prostate and make sure it doesn't feel like there's any cancer there. Remember, I told you that the cancer happens on the shell, right? So that's why when you go in the backside, you can feel that outer rind or shell of the prostate more easily and check for nodules that are concerning for cancer. And the PSA is a blood test, prostate-specific antigen, that is a blood test that can measure for your prostate cancer risk. It's not a perfect test. And it has to be interpreted kind of cautiously but it is, I believe, something that every man should be getting annually. Specifically, the reason I'll say that is because the real value of it isn't necessarily one number, but tracking that number over time. So the more years that you go and get it done, the more you kind of have those data points and that graph, and you could see, right? Look, you know this. It doesn't take a doctor to know this. If the number is here, and all of a sudden it goes, whoop, then that's something's going on, right? So it's being able to track it over time and see those kind of rises and falls and things like that that make it valuable. So PSA, I do recommend that. I don't know if Dr. Hart would agree, but yeah. There's some primary care. I mean, look, to be fair, it's a long lecture, but some primary care doctors have been led to believe or do believe that they shouldn't check it. And so, you know, I do mention that you should have that conversation with them because you may think they are and they might not be. And so it's a conversation worth having. When do we stop measuring PSA? It's really about your health, not necessarily a numeric age. We do recommend checking it until about 10 years, until you have about 10 years of life expectancy left. What can we do to treat BPH? So if you've got that benign, non-cancerous growth of the prostate, it's causing you urinary symptoms, it's impacting your quality of life, what can we do about it? Well, there's a number of options, all the way from just watchful waiting. So we know it's happening, but not quite bad enough to need treatment yet, all the way across to surgery on the far end here. And of course, everything's going to be very much tailored to what your specific needs are. 2:30. Okay, 4 minutes. Okay, so there's medication. That's generally going to be the first line to start. Those medicines are safe, cheap, and effective. So I would recommend we always generally start with that. There are really not a lot of disadvantages other than some sexual side effects, which specifically is lack of ejaculation, not necessarily impacting on erections or orgasm or anything else, since we're saying those words out loud today, but just simply lack of ejaculation. But we can work through that. Actually, there are some medicines that don't cause that. But if you need to move on to a procedure, or you don't want to be on a medicine and you just want to move on to a procedure, we have a number of very, very minimally invasive procedures that can be done. We are going to want to look in the bladder and look at the prostate. Like I said, just the way urine comes out, we go in. We can look with that tiny camera, get an ultrasound as well for the size. And then based on the size and shape, we're going to pick the right solution for you. So this is supposed to show you there's some prostates that are this size, some that are this size, and some that are this size. And so there's different solutions for each of those. There's something called UroLift, or prostatic urethral lift. That's a little tack that you put in. And basically, as I showed you, all that stuff collapsing, that tissue collapsing in, we can push it open and tack it back. Okay, it's like the little drawstrings that you have for your curtains at home to kind of hold the tissue open that had collapsed inward. So that is certainly an option. There are heat and steam-based therapies where we can actually try to kill off some of the tissue and shrink back that tissue as it collapses in there. That's something called Rezum. Or we can remove tissue. So you hopefully got to see those pictures along the bottom there that showed the various stages of the tissue encroaching and collapsing in. So again, doesn't take a doctor. You understand. You got to do something to open that thing back up. So we talked about pinning it back, or we can talk about actually removing some of that excess tissue. You don't need it. It's not doing anything for you. It's just grown up over your adult life and gotten in the way. So we can shave it back. We can do that with what's called a TURP, transurethral resection of the prostate. That's what the only option that really was available in your father, grandfather, uncle's generation. We do have a lot of other options though now lasers that can kind of shave away the tissue. As you can see here, we just kind of whittle it back until we get a nice open cavity and get rid of all that stuff that was in the way. Or one called holmium laser enucleation, which we're lucky enough to have a few people here in town that do. Most areas of the country don't have anybody with this expertise, but we do, and it's for the especially big prostates where they actually just kind of find that layer between the rind and the pulp and actually scrape away all the pulp and open it really up in a very nice way. So we do have, I know that was exceedingly fast to go through, and I didn't really want you to take away too much from those slides other than to say we do have options. They're tailored to each man based, number one, on your needs and your desires, your goals, and then also based on the size and shape of your prostate. We're excited to introduce a new treatment called prostate artery embolization, which is actually done by interventional radiologists, where they don't actually have to cut away or remove any of the tissue. But actually can go in just like any radiology procedure where they kind of go in through a blood vessel in your leg or your arm and go around, and they can actually block off the individual blood vessels to the prostate and kind of cause it to shrink back because they've kind of choked it off of a little bit of its blood supply. That's one that is totally non-invasive and really effective as well. So in other words, there's a very large spectrum of options. And again, 50 years ago, there was one. And it was not that pleasant, and you probably didn't want to do it. And so men waited till the very, very end until, you know, they were on the verge of not being able to pee at all to go to the doctor because the one thing that they could sign themselves up for was probably not that pleasant to begin with. Now we have an entire menu of options based on what your preferences, desires are, as well as the size and shape of your prostate. So it's a much better scenario than it was 50 years ago. And I do encourage you, if you yourself have these sort of issues, or again, if you're just in a conversation with a neighbor or a friend that does, the main message is you don't have to just suffer with it. You don't have to live this way. You don't need to be afraid of the solutions. Again, they have very few side effects. They're almost always almost exclusively outpatient procedures that you have done. You're not staying in the hospital. You're not, down and out. You're not bed bound afterward. I mean, it's just, they're very simple things that get you a whole lot better. And we hate to see men suffering through with these troubles. So I'll stop there. And we don't really have time for questions, but let's pretend we do if anybody has one.
I have one. One question. Dr. Liu, I had green light laser surgery about 7 years ago, but I was told that the prostate could grow back again. Is that feasible?
Yeah, it can. So, but we talked about how we just shave it open like that. And so it can over years kind of start to grow back. And it depends again on how genetically, how your body is programmed in, how aggressively it's going to grow. Because some guys, you open it up and it'll grow back real slow. So maybe the entire rest of their lives, they won't notice it. But if your body is dialed in to grow rapidly, then yeah, it'll start to grow back. And that may happen over the course of 7 years. And, if that's the case, we can talk. I mean, it's not something we want you to have to sign up to do every 7 years for the rest of your life. That's maybe when you go get that whole up procedure, because those guys can do it in a way where they kind of get right down to the roots and it won't have as much of a chance of growing back. Or whatever, we can talk about that. Any other quick questions? Okay, we answered it all. Okay, one real quick, yeah.
I asked a stupid question.
Oh, you're fine. No such thing.
What about a prostate implant?
Well, the only thing I would know along those lines maybe are these stents, prostate kind of stents that are implanted. Is that what you're saying? I don't know if you've, that's something that has been developed. We don't really do that much, but that kind of is, like I said, anything that pulls that tissue open. So there's these kind of little minimally bulky kind of metal objects that you can put in there and kind of hold everything open, stent it open. I'm not sure if that's what you're referencing.
I'm thinking about something that will help you with ED without having all this other things that you need in order to get erection.
Something that helps with ED, is that what you're talking about? Yeah, certainly. Yes, I talked about
say
that.
You use the needle and you use the pump and all of that.
Yes.
And it hurts.
Yep. Yeah, we definitely do that. Big fan of that, but unrelated to the prostate. But yes, big fan of that. All right, well, I will turn it over again.
Dr. Langston, thank you very much. You heard him mention that prostate artery embolization. A coworker of mine recently had that, and shameless plug, there's this, not featuring him, but there is a story on our website where we talk about the prostate artery embolization. So that is something to keep in mind that Dr. Langston talked about for enlarged prostate. We now want to welcome Shay Arluck to the stage. This is for Nutrition for a Healthy Lifestyle, Eating After Cancer. Registered dietitian, nutritionist, a 20-year cancer survivor herself. Helps to educate oncology patients and their families on ways that they can fight cancer both during and after treatment by fueling their bodies with sound nutrition. She teaches practical ways to follow the American Cancer Society's nutritional guidelines and teaches patients how to fill their plates with superfoods and powerful antioxidants and maintain their gut health and achieve a healthy body weight. Shay Arluck, warm response, please.
All right, last lecture of the day. Does everyone need to stand up for a second, take a deep breath, get the oxygen back into our brains so we wake up? Okay, just kind of move around. Just do a little bit of something just to kind of get that blood flowing again. All right, so 2,500 years ago, one of the first known Greek physicians, philosophers said that all disease begins in the gut. And he was correct, but we've kind of forgotten about that. Over the past 50 years in this country, we've seen a dramatic increase, unfortunately, in chronic disease. That's because we're forgetting about our gut. The gut microbiome, it's a big buzzword right now on social media and on the internet, is a real thing. If we can decrease inflammation in our gut, it affects so much of our physical and mental health. It helps with anxiety, depression, hypertension, cardiovascular or heart disease, obesity, high blood pressure, irritable bowel disease, and cancer. It is one of the #1 ways that I try to educate my cancer patients on how do we put more good bacteria into our gut instead of the bad bacteria. And it's possible. And we're going to learn those quick ABCs today, learning about anti-inflammatory foods and how they're key to our gut health and what to avoid. Unfortunately, bad news, bacon and other processed meats are a key component to inflammation. They are considered a type 1 carcinogen. Do you know what else is a type 1 carcinogen? Asbestos. So bacon, sausage, salami, hot dogs are right in the same category as asbestos. And then how do we fight the foods that, you know, we still need to eat, right? We still need to enjoy life, but we have to have that balance, and we can do that by having a brightly colored plate, which sounds pretty self-explanatory, but hopefully I'm going to give you ways to make it even better so that we can take food and we can be fighting disease instead of causing disease. All right, let's start with that A. Anti-inflammation is truly key. When you go to other countries that have cut out a lot of these seed oils that I'm about to talk about, or these highly processed foods, or high fructose corn syrup, they're living longer than us. They're feeling healthier than us. I did a recent trip to Iceland with my sister who has complete gluten intolerance in this country. In Iceland, she was able to eat every single bread product. The way we are processing our foods, the foods that are out on our shelves, and it's not all bad news, I promise, I'm going to give you food to eat, but the way that our American society, manufacturers, and the food industry is making our foods is making us sick. The human body contains 30 trillion human cells. The human body contains 38 trillion bacteria. We are more bacteria than we are human. which is also a strange thought. With that being said, we have to balance the good bacteria. The probiotics is a common term for good bacteria with the bad bacteria. We have to help that good bacteria grow. We have to take in that good bacteria and not constantly be taking in things that cause bad bacteria. Some we can't avoid. Stress causes bad bacteria. Lack of sleep, lack of exercise, but there's also foods that are causing bad bacteria and inflammation. And unfortunately, our standard American diet is making us sad. So let's talk about first what to avoid, so then we can talk about what to eat. All right, so the number one thing that scientists and researchers have found is that our foods here in this country contain so many seed oils. And these seed oils cause inflammation because they have a very low heat point. So when they are used in manufacturing, in processed foods, they are taken to a point that they basically become rancid. They create free radicals. That's bad. We don't want free radicals. So therefore, they cause inflammation in our gut. And once again, inflammation in our gut can lead to disease of both our body and our mind. So when you are looking at labels, we want to be avoiding canola oil, cottonseed oil, soybean oils, sunflower, safflower, peanut oils. That's a lot of oils. What it leaves us, the good, great monounsaturated oils, olive oil and avocado oil. These are great for you. They have a high heat point. Even coconut oil, as long as it's not processed, as long as it's not hydrolyzed, that's okay. So we have to look. I mean, obviously, fast food, you can pull it up on the internet and see what's in their products. But I can guarantee you, I actually worked with McDonald's for 10 years as their dietitian, which I know sounds like an oxymoron. I did bring on the oatmeal. So there was, or still is, a product that I would say is dietitian approved. But so many fast food items are using these oils. Frozen meals, protein bars, baby formula, which is very scary to me that even in baby formula, we're using these inflammatory causing seed oils, ice cream, oat milk and almond milk. If you can't drink dairy and you're using oat milk or almond milk, make sure it's just almonds and water or oats and water. Unfortunately, once again, our American manufacturers of our food industry are adding oils even to our oat milk and almond milk. Starbucks, almond milk, oat milk, not the brands that I would recommend. They do contain inflammatory oils. Nuts. I was shocked to find out that nuts can't just be nuts anymore. My husband every year from a patient gets Virginia peanuts, and we always eat them. I turned them around the other day as I was getting ready for this lecture. Virginia peanuts, canola oil, or safflower oil, and salt. Why do nuts need to contain oil? They naturally contain oil. Peanut butters. You have to be so careful. Simply Jif, which is supposed to be our, it's simple, it's natural. No, Simply Jif contains fully hydrogenated, and of course we don't want anything hydrogenated, vegetable oils as from rapeseed and soybean. And even microwave popcorn. Microwave popcorn contains oils. Our condiments, you have to look at your ketchups, your salad dressings. But as I said, it's not all gloom and doom. There are many bars and nut butters and popcorns and ice creams and salad dressings and frozen meals that do not contain oils. And if I had an hour to talk to you, I could give you all of them. But just so you know, a Lara bar costs the same thing as a Cliff bar. This contains inflammatory oils. This one does not. The Nature Valley granola bar, so many inflammatory oils along with artificial colors and processing. So we just have to read our labels. If you are someone with an iPhone, there's an app called Bobby Approved. It's free. It scans the QR codes while you're in the grocery store or at Target or the drugstores, and it will tell you right away if it contains those inflammatory oils or not. Now, the other problem we have in this country, which is absolutely causing inflammation, absolutely is part of the cause of our very sad guts, our very sad diets, and that increase in chronic disease in this country is the amount of added sugar we add. The average American takes in 70 grams of added sugar a day. This is about 280 calories worth of sugar, which is for men double what the body can handle to not lead to inflammation. For women, it's 2/3 more than the body can handle. So we really want to learn to cut the sugars, but yet we want to eat. We want to enjoy life, right? So there's ways of doing it. So I always, when I'm talking to my patients, I always say, okay, you're going to go for that coffee drink. What is it that you really want? Do you want the chocolate in there? Or do you want the whipped cream? Do we have to have both? And if we're going to a Dunkin' Donuts or Starbucks daily, A, do we need to? Why not save some money? B, we don't have to get the double whipped Java Frappuccino every single day. We can make things, obviously, with a non-fat milk, but we can also skip the syrups and we can skip the whipped cream. Watch that term fat-free. So yogurt is wonderful for you. Yogurt contains great probiotics. That is good bacteria. That's great for your healthy gut. Fat-free yogurt usually means tons of sugar. Sugar does not contain fat. I had a patient years ago telling me that she ate a completely fat-free diet and she did not understand why she had to have a triple bypass of her arteries. That's because she ate fat-free products all the time that were high in sugar. Of course, avoiding over-processed foods. We kind of talked about that from the oil standpoint, but also the sugar standpoint. Being careful even with your condiments. Ketchup in other countries doesn't contain sugar. Barbecue sauce, mustard in other countries do not contain sugar. You can find those products here, but you have to look for them. And if you tell me, well, I've got a sweet tooth, I'm not going to like it. The good news is the taste buds on your tongue turn over every 30 days. If you start using lower sugar products, you will find that you will enjoy them just as much. Maybe not tomorrow, but you know how, I don't know, those of you who are parents, we always say we're going to try something 10 times before we're going to accept that our kid doesn't like something. It's the same with adults. We're no different than what we're telling to our kids. Avoid canned fruits and canned vegetables. A lot of times they contain sugar. And honestly, when I'm talking to people how to eat healthy in an economical way, I love frozen fruits and vegetables. I would advise everyone stocks their freezer with frozen fruits and frozen vegetables. A lot of times organic frozen fruits and vegetables are cheaper than the ones you're going to find right in your grocery store on the shelf. Now, I'm not telling you not to eat fresh fruits and vegetables, but because, as I'm about to talk about, we should be having at least 5 cups of fruits and vegetables a day minimum. Stock your freezer with frozen fruits and vegetables. Once again, check the labels, make sure it's just a green bean, not a green bean that has safflower oil to it, or it's just blueberries, not blueberries with sugar, and use them from your freezer. They last forever and they're a lot cheaper. And then I always tell people a rule of 2. I have a sweet tooth just like anyone else, but if you do want something sweet, try to limit it to a 2-inch square or no more than 2 small pieces. If there is something sweet you're craving, you kind of want to think of it like a bottle of fine wine. I don't know if there's any wine drinkers in the room, but if there's something you really want, this goes for French fries too. Take it, look at it, smell it, lick it, really enjoy it. Take a small bite, savor it. I promise you, you will not eat that entire box of Girl Scout cookies if you start with the first one this way. You will not eat an entire thing of fries or chips if you start with it this way, because your body will, yes, enjoy that moment as it should. Food should be enjoyable, but you won't feel the need to keep eating more and more. And of course, read the food labels. High fructose corn syrup is a #1 thing that basically in your mind should say inflammation. Corn sweeteners, corn syrup, malt syrup, all the things you see up there. All right, now some of the positives. So how do we make good bacteria grow in our body? Well, we can take it in the form of probiotics, fermented foods like yogurt and kefir and kombucha and tempeh, miso. There's a lot of great live active cultures in our food supply. Or we can take in prebiotics, which is the feeder of probiotics. So prebiotics feed probiotics, and to take in prebiotics, we just need to think brown, think about whole grain pastas, brown rice, quinoa, chia seeds and flaxseed, especially if we're talking about cancer prevention. You all have a sheet on your table that I created, and it's basically 7 things that you can do daily to try to help prevent disease. Or if you're currently in your cancer journey, it also will help you be less inflammatory and help your cancer treatments work better. So we want to get in those seeds. We want to get in the oats. But there's more than just that. Foods like garlic, onions, bananas, asparagus, apples, avocados, all of those help feed the good bacteria, helping the good bacteria win, helping the good bacteria take over, decreasing inflammation, decreasing disease risk. All right, so we know now how to cut inflammation, but let's talk about a key inflammatory food, and this is processed meats. So as I said, if they have been labeled now as a group 1 carcinogen, does that mean you can never eat bacon again? No, it doesn't mean you can never eat bacon again. It does mean you should limit it. So we should be limiting our processed meats. So we're talking bacon, salami, pepperoni, sausage, hot dogs to 0 to 1 times a week, ideally 1 to 2 times a month. 1 serving. So that would be 3 slices of bacon, 1 hot dog. A recent study came out that showed 1 hot dog daily, or its equivalent, bacon, sausage, whatever, increases one's colon cancer risk by 36%. And we are a country that loves our bacon and hot dogs. So, same thing. Once, twice a month, look at it, smell it, lick it, taste it, savor it, treat it with the respect that you want to give it so you can enjoy it, but don't make it the main part of your meal. When we're talking about red meat and trying to, once again, fight inflammation, fight disease, fight cancer risk, we also need to just think about our regular red meats. Once again, we can enjoy up to 12 to 18 ounces a week. So if you think about the palm of your hand, that's about 3 ounces. So you can have 12 to 18 ounces a week. However, it's best to cut away visible fat. It's best to go for a cut that has the word loin in it, tenderloin, sirloin. And of course, only use it occasionally. Go for plant proteins, go for white meat. Unfortunately, processed meat and red meat have been linked to prostate, stomach, colorectal cancer, and pancreatic cancers. All right, how are we going to fight all of this? So, you know, this morning we had a biscuit with some gravy and some bacon, and we're thinking now, oh, she's just ruined my day. How do I fight this the rest of the day? Nature has given you a way to fight it all. Now, that doesn't mean that I want you to eat bacon every day and then do what I'm about to say. But it means that when you do want to enjoy a food that I've just said causes inflammation, you can fight it with what we're about to talk about. Those are brightly colored fruits, vegetables, herbs, and spices that nature gave us. So bad news, Gatorade, M&Ms, gummy bears, they don't cut it. But everything that nature gave us has wonderful beneficial properties. Yellow from yellow apples, bananas, and peppers, oranges, turmeric, purple, anything from grapes to blueberries. Red is our strawberries and other berries. Greens, including all of our leafy greens. When we're talking about cancer prevention or in your cancer journey, you'll see that is my top square. I am a firm believer in all the amazing nutrients in leafy greens, and I don't care if they are fresh or frozen, but you should be taking in 1 to 2 cups every single day, whether you mix it with your eggs, put it in your smoothie, go to Subway and ask for extra spinach on your sandwich, put it into your casseroles. Those leafy greens are so important. And even our white vegetables, like our cauliflower, all have beneficial properties. And as I said, it doesn't stop with just that. Go back and look at your spice cabinet, maybe weed through it and get rid of the ones from 1970. Toss those in the trash can. Restart your spice and herbs and think beyond salt and pepper. You can see right here that there are so many natural, amazing reasons to eat ginger. I use ginger all the time when patients come to me and tell me how nauseous they are from chemo. I use turmeric to help people with mouth sores from chemo because turmeric is a natural anti-inflammatory. So I help them make a turmeric paste to put on their mouth to help with mouth sores. Cinnamon is wonderful. Some people believe cinnamon helps to lower blood pressure. Studies are still back and forth on that, but cinnamon has powerful nutrients in it to absolutely help fight inflammation. So adding cinnamon to your coffee every morning, if you're a coffee drinker, sprinkling it on your cinnamon. So just thinking beyond the salt and pepper shaker, really looking to get in those 5 cups a day of brightly colored fruits, vegetables, and herbs and spices. So to end, we're going to do a quick little, which one should we go for? So talking about bright colors, talking about fighting inflammation, talking about avoiding those processed meats. Should we go for the sausage biscuits and the eggs with the side of a biscuit? Or should we go for some eggs, but with a side salad with lettuce and tomato, and maybe we've got some pepper and turmeric on it? Or the oatmeal or the acai bowl that's filled with brightly colored fruits and vegetables that we've sprinkled chia seeds on or flax seeds on. We all know the answer, right? All right, lunchtime. Should we go for the Philly cheesesteak with the side of fries? Looks good, but how many colors are we looking at? Maybe 1. There might be a green pepper in there somewhere. Instead, if you're craving fries, that's okay because life is about balance. But with those fries, we should have a great big salad that's filled with all kinds of different colors and vegetables and nuts and seeds and a plant-based protein. So maybe a garden burger or something like that. As I said, if we go to the sandwich shop and we want a sandwich, that's okay too. A whole grain or multi-grain bread would obviously be the best, mustard being better than ketchup so we can avoid the sugar, avoid those seed oils, and then ask for every extra vegetable that you enjoy, the lettuce, the tomatoes, the onions, the pickles. Fill up on all of those. I don't know if you can go to McDonald's and ask for all those extra vegetables, but you definitely can go to the Quiznos and Subway and all of them. And then for dinner time, we're thinking about making fried chicken for dinner, serving it with the mac and cheese and a side of bread. We're just asking our body to be inflamed. Instead, we can have baked chicken with every vegetable out of your freezer. Once again, you don't have to keep fresh vegetables on hand to get the benefits. pull them out of your freezer. When I make my oatmeal in the morning, I literally take my oats, I take my milk, I put it in the microwave, I dump in, and my microwave is purposely right next to my fridge and freezer. I dump in a scoop of frozen blueberries, put it back in my microwave for 30 seconds, throw on some flaxseed, once again out of my freezer because it keeps it more stable. And I am starting my day with a great anti-inflammatory boosting breakfast. So same thing goes with dinner. We want to see those bright colors. So to start right now, today, what I recommend is your next meal that you eat, think about those colors. Make sure brightly colored fruits, vegetables, herbs, and spices are what you're thinking about first. Then pick the protein, then pick the carbohydrate. So disease prevention truly starts with our ABCs. Read your labels for added sugars, seed oils, focus on whole grains. If you can make your own salad dressing, do it. If you can't make your own salad dressing, balsamic vinegar and olive oil go a long way. When you're looking at foods to buy at the grocery store, go for just a few ingredients and make sure you understand what you're reading on your label. And once again, olive oil and avocado oil are best. Limit your red and processed meats to 12 ounces per week for your red meat and no more than 1 to 2 servings a month of your processed meats. This change in itself, if everyone in this room could limit their processed red meats to 1 to 2 times per month, I promise you will make a huge difference in your health. And finally, look down at your plate. Every time you eat a snack, 2 bright colors made by nature, not made by gummy bears and Gatorade, should be staring back at you. Your meals, 3 bright colors should be staring back at you. If we can work to take care of our own bodies, if we can be our own health advocate, we can move towards a society that is like Japan and that is like Sweden and that is like Iceland, and we can live longer, healthier lives. Thank you. So I'm sure I overused my time, but if you need to get a hold of me, my Instagram and Facebook are at the bottom. You are welcome to always direct message me. I also put out cancer fighting recipes every other Friday on Sentara Brock Cancer Center's Facebook page that you can pull. And I'm working on a cookbook, but it's not there yet. So thank you.
Okay, so I enjoyed that. I mean, it was fun, it was fascinating, and very informative. All right, that we can retrain our taste buds. So our taste buds that say that bacon is so awesome, which it is. What if we sprinkle cinnamon and cayenne on the pepper on the bacon? That no, so God, twice a month for. We can do this if we want to live longer, healthier lives. I mean, and that's, I mean, all of this we have to process that we learned today is, do we want to put it into practice? I mean, do we just want to know it, or do we want to put it into practice? And the changes that we can see just on all the things that we talked about. I mean, how to improve our sex lives, how to improve our gut life. Just a lot of information to process. So there are evaluation forms on your table. Please take time to fill those out so we can know what we did right, what we can work on. I also want to acknowledge John, who did not want to be acknowledged, but he's on audio. He's with Encore Audio and Visual. And, you know, you've got all kind of different speakers who came to him with all kinds of stuff. And the reason it worked out so well was because of John. So John, thank you so much. I got to thank Lindy right here. She doesn't, but Lindy, Dr. Langston already acknowledged her, but I mean, to pull this off. So there are vendors outside. So for those of you who you know maybe didn't feel comfortable about asking certain questions, the vendors are outside that you can kind of directly speak with them and get more information, pick up their literature, so that we can go on to having healthier, longer, more productive lives. Thank you for letting me be your MC. Again, thank you for filling out the forms, and thanks for joining us today.